I would like to welcome everyone to today's webinar, Compassion Integration, Connecting Hearts and Minds with Action. I'm Andrea Greenberg, Communications and Partnerships Associate at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. We will be polling the audience during today's session, and we hope that you will participate in this interactive measurement tool. Finally, as you exit the webinar, you will receive an electronic survey that we ask you to take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it is my pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Andrea, and good afternoon. Thank you all for joining us for our 2017 webinar series on compassionate collaborative care, or what we call the CCC. The Compassionate Collaborative Care Framework describes some of the key values and behaviors that help us offer this kind of care to patients, families, colleagues, coworkers, while also sustaining ourselves and our sense of meaning in the work. This framework is available on our website. This year's webinar series, we're focusing on creating organizational cultures of compassion and collaboration. This is also the focus of our inaugural annual Compassion in Action Healthcare Conference in Boston, June 25th through 27th. This year, we have an amazing lineup of fantastic, innovative speakers for this event. This will be very dynamic, interactive, participatory. Please visit our website and be sure to register to attend. So let me introduce today's session, Compassion Integration, Connecting Hearts and Minds with Action. This presentation will describe the process that Providence St. Joseph Health has taken toward embedding compassion throughout the culture of the organization. My good friends Becca Hawkins and Mark Rosenberg will take you through their compassion journey, articulating the successes and barriers to this work. They'll describe how a message integrating suffering, compassion, and burnout resonated with leadership and caregivers. In addition, they'll demonstrate how creating collaboration and synergy among key partners facilitated the integration of compassion into clinical services, quality, high reliability, and several work strands of human resources. Finally, they'll include some specific examples of compassion innovations that have been particularly impactful. So by the end of this session, we hope that you will be able to describe key concepts connecting suffering, compassion, and burnout, discuss the integration and collaboration process for embedding compassion throughout a system, and adapt compassion innovations to your own healthcare systems and needs. So now I'm honored and absolutely delighted to introduce today's speakers, Becca Hawkins, MSN, ARNP, and Dr. Mark Rosenberg, MD, FACP. Both are directors of compassionate care at Providence St. Joseph Health. Dr. Rosenberg is also an internist and a faculty member with the Internal Medicine Residency program at Providence Portland Medical Center, and Becca is a nurse practitioner with a specialty in oncology, hospice, and palliative care. Welcome, Becca and Mark. I'm going to turn this program over to you.
Thank you, Beth. Becca and I and our two teammates, Laura Daniel and Krista Nelson, really want to thank you and the Schwartz Center for inviting us to share our journey that we've had in strengthening the culture of compassion at Providence St. Joseph's. It's the beginning of a journey. And so what we're going to share with you is a work in progress. Today, what we'd really like to do is to share some of the lessons, some of the tools, the models, the messages that we've used sharing directly what we've said, but also talking at the meta level to explain rationale or impact of some specific elements. We share these experiences with you with humility, knowing the broad and deep expertise that's represented on the call today, knowing that these approaches are not one size fits all, but we're trusting, hoping that each of you will be able to discern nuggets that will be relevant to you and your situation and to your organization. So, Becca and I first met in Haiti. We were part of a discernment process for Providence. We were there less than a year after the major earthquake of 2010. We were shaken by the tent cities that had sprung up for the newly homeless, by the cholera holding areas throughout the country, a new disease added to a devastated landscape. We were stricken, as is shown in this slide, by the collapse of one of the major teaching hospitals, Francis de Sales in Port-au-Prince. And the collapse of this building represented the death of an entire class of nursing students. At the same time, we were amazed by the loving energy of the people of Haiti, the healthcare workers that carried on, the caring that they demonstrated toward each other, even in the time of extreme need-resource mismatch, and the caring that they demonstrated toward us, people coming to help without any clear idea of how to help. As Becca and I talked late into the night, talks that without us really knowing it, laid the foundation for this work, we realized that the loving energy of the people of Haiti was really compassion. Compassion that was sustaining in the face of potentially overwhelming suffering. As we returned to the United States, as we returned to our jobs at Providence, we recognized that suffering was present here in our own country, here in our own health system. It was different than what we had seen, different in intensity, different in specifics, but also in its own way overwhelming. We also saw that compassion was present, but that it didn't seem to be as central or as energizing as what we had seen. And we asked, what was our calling? What were we called to do to make that different? So, as Beth said, what we would like to do today is to talk about connecting the suffering, compassion, and burnout as concepts that underlie this work, to really stress the importance of collaboration and hopefully give you ideas that you will be able to bring forward as innovations within your own health system. 2 years ago when we began this work, we were Providence Health System. We were a 5-state system, 76,000 caregivers. Now, 2 years later, we've blended with St. Joseph Health. We're 7 states, 106,000 people. We're faith-based, we're secular. And this is really the playing field for our work of compassion. And as a palliative care nurse practitioner, and as a longtime program director, pictured here, this is not work that we anticipated doing. We've never been trained and never contemplated or expected to be doing organizational change work. But we have been transformed in this work. In many ways, we've walked the path that's open to us. It's been a curvy path, a bumpy path, full of unexpected things, but we've continued to walk forward, and that path is the one we wish to share. We have used Kotter's process for leading change, both in thinking about how to do our work, but also for structuring this talk. We're going to focus on the 3 large areas: creating a climate for change, engaging and enabling, and implementing and sustaining change, and give examples of what we've done within each category. And in the process of full disclosure, want to say that we are really in the transition between step 2, which actually never ends, and step 3 of trying to figure out how to create sustaining change. So step 1 of creating a climate for change, as we've reflected back, these are the 4 important pieces that we want to share with you. Steps for creating a burning platform, the importance of data, looking at some of the key principles that have animated and defined our work. And one of the things that we have found very important is the utilization of sharing of suffering in terms of energizing compassion. So as we've looked at how we created our burning platform, we were fortunate that compassion was central to our mission and values. We quickly came to the idea that making the suffering, revealing the suffering of caregivers and allowing it to be discussed was very important. This was not a simple conversation within our organization. There was concern from leadership that really discussing openly suffering would make it worse. We then have utilized the suffering that was discussed to connect it to burnout and the connection of burnout to all of the different outcomes that are of interest to different constituencies. So our mission within our organization fits beautifully with compassion work. The Providence mission talks about compassionate service to the poor and vulnerable. And one of the key things that we have talked about is the idea of caregivers as part of that poor and vulnerable. And St. Joseph Health brings a similar commitment to compassionate care. And within our promise statement, it contains the 3 elements of compassion: know me, care for me, and ease my way. And this has been a very strong foundation, pre-existing before us, but a very strong foundation to build our work on. It's provided justification for the conversation around compassion all through our organization. And so as you listen to this, to think about what is the mission of your organization, because virtually every healthcare organization, whether it explicitly or implicitly uses the word, includes the concept of compassion. And as we went through our organization, we provided exercises and forum for people to talk about what was really going on in their hearts and the suffering that they were feeling. We looked at the words and created themes. And then as we talked, we shared those themes in ever-enlarging circles throughout the organization. And what we found is sharing it normalized it, validated caregiver suffering, and also validated and normalized the suffering of leadership. We then moved forward to connect that suffering to burnout and connected burnout to all of the different outcomes of the quadruple aim, and held out at each step compassion as part of the antidote to that suffering. And what we found was words took us only so far, and that we needed to support the words with data. At first, we utilized data from national sources. Shanafelt's data about physician burnout, I'm sure everyone on this call is familiar with, showing a 45% average burnout rate for physicians in 2011, and then increasing until a burnout rate of 54% in 2014. This energized people and concerned people. What we found was important to us philosophically was this is not just an issue for physicians, that this is an issue across the entire healthcare spectrum. And so we've always been very careful to include all elements of the healthcare system as we've talked about suffering, burnout, and compassion. We made use of national data from the Schwartz Center that reported that only half of physicians and half of patients feel like they're working in a compassionate environment. And also national data that connected burnout and well-being to patient safety. And so as we move to the next slide, I'd like to turn this over to Andrea to facilitate the question.
Absolutely. Thank you very much, Mark. Our first polling question should be appearing on your screen and reads, how does your organization measure burnout and compassion? Please select all responses that apply. Validated questions of burnout, proxy measures of burnout, validated measures of compassion, proxy measures of compassion, or not currently measuring. So please go ahead and select which answers apply to you, and shortly afterward, we will reveal the results. All right, fantastic. Thank you very much, everyone, for selecting your answers. We have a good response. So let's go ahead and close the poll and share the responses. Let's see, we have 20% said validated questions of burnout, 16% said proxy measures of burnout, 11% said validated measures of compassion, 10% said proxy measures of compassion, and 70% said not currently measuring. Rebecca and Mark, any thoughts on these results before we jump back into the presentation?
Yeah, this is Mark, and I think what that speaks to is the difficulty of measurement and the difficulty of getting the organization to agree that these are things that are crucial to measure in the context of so many other things that they're concerned about. And so part of what we want to do is to share some of the experiences we've had with measurement and hopefully use that to encourage people to measure, because as we all know, attention focuses on those things we measure. So I think we'll move forward. Okay, and so one of the first steps that we had in developing internal data, because what we found was national data was great, that we would think about, well, probably Providence is like national data, there's no reason to think we're different, but it was not energizing in the same experience as we've had now with internal, our own data. So our first experience of that was actually done by our HR partners. They asked a broad survey of caregivers, what are the words that describe the culture that you wish Providence would be? And so, as you can see on the slide, clearly this was great support for the work that we would want to do. Next, we partnered with Press Ganey and asked them to add a customized question around compassion. And the question was I shown compassion by the staff? And those are the results from our organization, which are not so dissimilar from national data, but we have over the last year and a half seen increase in that. I also want to point out one of the challenges we've had is our medical group has not utilized this question, but rather the question they use is, was the staff sensitive to my needs? That drives a different set of responses when we get that data. What has had a lot of resonance within our organization is then doing correlative stuff. So when we look at the question, was I shown compassion by the staff? If the compassion shown by the staff was rated a 5, so the best rating through Press Ganey, over 90% of the time in every setting, the patient rated quality of care as either a 9 or a 10. As compared to when compassion was rated anything less than a 5, the quality of care was rated much lower. this was a really important way of tying quality to compassion and bringing in another set of allies within our organization.
One of the other things we did very early on in this journey is to socialize key principles, and we developed these initially for ourselves, and then later found them to be very useful to socialize throughout the organization. So we called them grounding principles, and we're just going to share these to you just to give you some food for thought. So the first is we really believe that compassion is innate and that there are barriers to giving your best self or your most compassionate self. And so that was the part that we needed to figure out what the barriers were so that we could unleash people's innate ability to be compassionate. We also felt that to be compassionate meant that we had to start with ourselves. So we've messaged a lot around self-compassion and around our own suffering as a vehicle to then being able to relate well to other people's compassion and suffering. The third grounding principle that we decided amongst ourselves was that compassion is an authentic connection between people. And we really challenged ourselves to think about this not from just the provider to patient experience, but about how we treat each other in every situation, about how we treat even beyond our teams. For example, how do we respond to the person that we see in the cafeteria taking our money for our food? So it was about every interaction with every person. The other message we started really working on is multi-directional compassion. So no sooner than we had been started in this work than we were finding ourselves in the midst of needing to downsize part of our organization. And that was really painful for us because Mark and I had a very good friend who was actually being laid off. And it was in that moment that we really challenged ourselves to say, hey, wonder what would it be like to have compassion for the people who were making these decisions? Instead of just feeling angry about it, maybe we could be curious about how the leaders felt in making hard decisions. And that really led us to asking our executive leaders that question. How does it feel for you to make hard decisions? And it was so revealing to us how much suffering they had in themselves in making, all sorts of really complicated, complex decisions for a large organization. The next thing is that we talk about compassion as being rejuvenating, not draining. I'm sure all of you have heard people say, oh, I just don't have time to be compassionate. And what we really try to, I think, message to people across our organization is that compassion, once you start giving it, comes back twofold to you. Another grounding principle that we've really held true to is that compassion is what we all do together. This is not just our work, the small compassion team, but it's the work of all of us. So we, again, have many different facets of our organization, mission, patient experience, HR, safety, reliability. I mean, you could go on and on and on. We all have many departments. It is the combined work of everybody. No one single entity owns compassion. And that was really important for us to make sure that everybody was on the same thinking. The next was that compassion energizes every other strategy in the organization. I'm sure any of you who have started this work have people say to you, is this just another initiative? Is it the flavor of the month? And we've always answered that A, we're not an initiative, and B, we are the catalyst and the energy behind all the other good work that is being done. When people feel compassionate towards each other, they want safety to be in the forefront of their patient care. They want to build healthier communities. So compassion is really the energizer and the driver. And the last one for us is that compassion should be encouraged and expected and really the focus of leadership. That leadership's role is to just create this opening for compassion to grow and flourish in whatever team or region or area that they lead. So we really messaged those key principles across our organization, and it really helped people get grounded in the same thinking. The next thing we did, as Mark also sort of alluded to, is we started talking about suffering way early on. We recognized that suffering, or you couldn't talk about compassion without talking about suffering, that it is the suffering and the recognizing of suffering and then being called to an action to do something about it was really the cultivation of compassion. So we set out talking about suffering. And in the process of doing that, the first thing we did, in a very innocent way, is we developed a reflection around the silent suffering of leadership. A reflection is something that we open up all of our meetings with. However big or small the meeting might be, there's a reflection. It can be a story, a prayer, a variety of things get shared in reflections. But we wrote around the silent suffering of leadership, really speaking to the hearts of leaders, of saying how hard it must be for you when things are happening around you and your job is to keep the stiff upper lip or to deliver a message that you don't believe in, and then how that creates suffering within yourself. It was very opening. It was a very, I think, pivotal moment for us as leadership, for them to say, wow, I get this. They're talking my language. They understand me. We then developed an experiential exercise around suffering, where we have a way of asking people to write about a time that's hard for them and how they felt on cards, and a very safe way of being able to share those cards to a larger audience. But in the interest of time, we won't be able to tell you more about that, other than to say that exercise has been very opening to our organization. It normalized the fact that all of us, every single person, holds on to suffering. We come to work with our best intention and our best faces on, but inside of us, all of us are holding grief, some sort of angst, some sort of worry. And just to know that we all do that and to be kinder and softer to each other really started to, again, make people think about, I wonder how I could look at the person who's being difficult in a different light, or how can I bring more caring to my teammates. Then the next thing that I think we sort of stumbled upon was to create this strong connection between the suffering, burnout, and then well-being and compassion. We were lucky enough at the time that when we started doing this, the nation really exploded with a lot of interest around burnout. So we've been able to sort of connect these constructs together of what you see in the popular literature, as well as what we are messaging within. The next step is about engaging and enabling. So I would, as Mark suggested, this is kind of where we are sitting today, and we're going to talk to you about some of the things we've done there. So the first was to gather the caregivers' voices, reflections, and stories. We go in very different venues, talking to people about their stories and their experiences around suffering and around compassion. We collect those and we redistribute them, so to speak, across the organization. So sometimes people will pick up another person's story to use as a reflection. I want to briefly tell you about a story of the falling man that you see in the bottom right-hand corner. This is a story from one of our chaplains who was telling us about a time he was called to the ED for a woman who was Hispanic, Spanish-speaking only, who brought in a lifeless child. He was asked to comfort this woman and felt very inadequate because he was unable to speak Spanish. And he was telling us about the great angst and really concern he had for this woman and how limited he felt in the fact that he couldn't comfort her well, but he was doing his best. And at the same moment, he was trying to comfort her, knowing that she had other Spanish-speaking clergy coming to her. He could tell that there was some commotion in the other room. And it wasn't until he was made sure that she was in a good place with her clergy in place that he walked out of the room, that he remembered what he heard, sort of this rustling and frenzy in the other room. When he walked out, he glanced into the room and he saw a body that was completely covered in a sheet, including the face. And he thought to himself, I wonder if this is somebody that we would all know, that there was maintaining this level of privacy. And then he started asking the staff, so what happened? What happened here? And the staff looked very distraught and told him that all they knew was this was a man who did not have family, had been seen by one of the doctors in the office building, and had received some very terrible news. They really weren't sure all of what had happened. But the man was distraught enough that he went to the top floor of the parking structure and leaped to his death. So the chaplain was holding the obvious suffering and angst of the staff. And once again, he got paged. And this time it was to come upstairs to see a young woman who was sitting vigil with her grandmother. When he went to this woman, he said, he was expecting to hear my grandmother's dying, and, she was having a lot of trouble with it. But actually what the young woman said to him is, I'm sitting with my grandmother and she's actually doing better, which I'm really thankful for. But what's been really hard is I was sitting there and I stood up to look out her window and I saw a man leap to his death. And so this story has been so impactful for Mark and I, because obviously it's a very impactful story, but the other piece of this is that we were really hit and understood for the first time that what happens, the suffering that happens in one department, for example, in a hospital, can ripple throughout an entire organization. And we also recognize that that could happen with compassion, that what could happen in one area with one group could ripple out through a whole organization. So we've always really kept the story close to our hearts. The next thing that we have really focused on is what to do with leaders. When we started in this work, we really felt like we would start with the people for the people, because that's who we were. And so we really innocently thought that we would just sort of help leaders understand what we were doing, but we didn't really think that we would get so involved with them. What really happened, this is sort of the trajectory we're on. We started out by informing them of what we thought they would like to know about compassion and burnout and suffering. It didn't take us very long, as we're describing to you, to understand that we not only had to inform them, but we needed to engage them. And we engaged them through the process of really touching their own suffering. And for them to understand that they didn't have to fix everything, that they could just be with someone suffering, and that in itself would be healing. And that's really what started to create the transformation that we're seeing in our leaders. They're now talking about suffering. They're now asking about how best to hold someone suffering. And they're getting more and more comfortable in a way of just being with and not trying to fix. And so the last piece of this that we're working on is how to develop compassionate leaders who will lead in a different way. And we're doing that through several different avenues. First is with our HR partners in developing leadership development curriculum and processes that will really help leaders approach their leadership in a different way. We have a large nursing academy and institute that is developing nurse leaders, and we are helping in all sorts of areas develop curriculum and mindfulness for nurse leaders. And then we are also beginning to look at a process of how to embed mindful leadership throughout our organization, regardless of where you sit, and really coming to your work in a more thoughtful, mindful, slower paced way, instead of being so frantic and I think sort of that nervous energy that we sometimes all feel, to slow ourselves down to lead in a very thoughtful, caring way. So all to say that we really, from the very beginning, knew that you couldn't shout from the top, from the system, be compassionate as a directive to people, that we were talking about caring for the hearts of people. And so we very quickly had to believe that the TOPS approach was to create this opening to encourage and to really cultivate compassion. And again, not to fix what was hard for people, but to be open to hearing their suffering. And for the people, the frontline caregivers, to really know that we could hear suffering. We knew that healthcare was hard. It wasn't always joyful. And we really wanted to empower the way they went about looking at how to cultivate more compassion.
Becca has described some of the ways with exercise and language that we have engaged both our leaders and our caregivers. The other piece of that, as I alluded to earlier, is what do we measure? How do we measure? And we've started a process of system-wide measurement of burnout and compassion. But before we go into the what we measure, taking the pause to reflect on why are we measuring? Is it to make a judgment that our caregivers are insufficiently compassionate and they need to do something to do better? Or is it to call out the fact that the organization needs to figure out how to do better support of our caregivers? When we measure burnout and compassion, are we looking at a reflection at the individual level, or are we looking at the organizational level? When we do, what we found is when we talk about individual resilience buildup, there's a challenge of, is mindfulness for the individual a way of allowing them to deal with a toxic environment? And what does the organization do to reduce the stress of the environment on the individual? And the other piece that we found very important is our organization is very used to talking about engagement. Are people engaged in their work? That reflects a caregiver's relationship to the organization. It doesn't express the way the organization cares about the individual. And so we've been really conscious of trying to cultivate a bidirectional relationship between the individual and the organization around issues of burnout and compassion. So as we've looked at our measurement strategies, then we have several that are shown on slide 42 that we've measured at the patient level, the Press-Ganey data that I showed you earlier. And we would invite anyone who wished to talk to Press-Ganey about including that customized question to please do so. This year, for the first time in October of 2016, we included through our caregiver surveys 3 burnout questions, 2 single items that are validated through work from the Mayo Clinic about I feel burned out from my work, I feel more calloused, and another one around meaning and purpose. And then 3 compassion questions, one about my supervisor promotes and supports compassion, my organization promotes and supports compassion, and I feel capable of giving compassion to colleagues during my work. We continue to work with our medical group to try and have them answering the same questions as the rest of our caregivers, but currently they use a proxy measure for compassion. My work gives me a feeling of satisfaction. And then on the next slide, you can see that when we've now done our institutional measurement on the last survey in October, we had almost 55,000 responses. You can see the range by position of burnout as defined by the single item burnout question, and that overall in our organization, representing burnout at a 48% rate. That has gotten people's attention. And then on the next slide, we begin to tie burnout together to engagement. And what you can see, if you look in the center circle, that overall in our organization, shown in green, we have 43% highly sustainably engaged, and shown in orange, 15% disengaged. If you then look at the not burned out circle, so these are people that did not report burnout, much higher rate of highly sustainably engaged. And conversely, if you looked at the people who report burnout, much less engagement, much more disengagement. And then we took the next step on the next slide, which shows the correlation of burnout and the ability to give compassion, self-reported ability to give compassion. So in looking at this slide, if you first look at the 4 left-hand bars, in the green, these are people that on their caregiver surveys reported in a way that they were not burned out and that they still felt able to give compassion. So they had a high, sustainably engaged, and a very low disengaged rate. As compared to those people who self-reported burned out and not feeling any longer able to give compassion, a huge disengagement rate. And then if you look at the right-hand 4 bars, that translates into their intent to stay within the organization and attrition. We know from previous data within our organization that if someone says they intend to leave the organization, there's a 25% chance that they will actually leave. And so if you were able to reduce the number of people who are burned out, not able to give compassion, you would predictably reduce the attrition rate.
On step 2, continuing on that journey, we then want to talk about how we develop compassion infusions. And we call them infusions versus interventions because we wanted to give the concept that we have compassion. We just need to give it a bolster. So you can see in this slide, we think of infusions in 3 different ways. There can be a standardized infusion, which means we would develop something and then it could be migrated out throughout the organization. There could be a way to do it with innovation with the team on the local ground, or there could be a co-design way of thinking about infusion. So some examples. In the standardized infusion, we did this when we did a pilot with our medical teams. We developed a compassion curriculum where we actually had mindfulness, a short lecture, group activity, and more mindfulness. That is the curriculum of 12 sessions that we've put together that we can bring to medical groups if they so choose. So that's very standardized method. The one that I would describe around innovation is that we talk about empowering compassion activities. We've done this in the hospital, for example, where we developed affinity groups, which was bringing people together, empowering them to think about how they would bolster compassion in their area and let them run with all new ideas. So this is the real innovative approach to making compassion infusions. And the third is a co-design. So we're just getting ready to work with the ICU nurses on a co-design way of thinking about what are some unit resilient practices that they would like to put into place. And we are planning to measure that in accordance to how much that impacts burnout and resilience. So that's how we think about developing compassion infusions. Next, I'd like to share with you about a resilience framework. So this is a framework Mark and I have been developing over the last few years. Again, we very much did not want to say to people, you know, here's the 5 things everybody should do exactly alike, and this will make you more compassionate. Because again, every team, every region, every hospital has its own culture. So we developed this framework of connection, reflection, protection. And what that really means is that we are giving this framework or buckets for people to know where to start in developing some of these infusions. So as we all know, when people are feeling burned out, they get very pulled in. So connection is how can you develop more connection in your team or within yourself? Reflection is how do you learn to take the pause? How do you take a moment to say, ooh, how am I feeling in this moment? You know, am I feeling stressed, overwhelmed? How's your team doing? So reflective practices as a team of saying, ooh, let's think about how our team is handling all the deaths that we've seen in the last month. Protection can be everything from taking care of yourself personally, you know, how you exercising, eating, sleeping, to how is your team doing in setting boundaries with violent patients or the angry physician, or, you know, so all of these ways of looking at what you could drop into these buckets have been immensely helpful for teams and individuals. On the next slide, I want to talk a little bit about implementing and sustaining compassion. So this is the third step of the model. And before we do that, in talking about both integrating and diffusing, I'd like to turn it back over to Andrea to do our next polling question.
Absolutely. Thank you very much, Becca. Our second polling question should be appearing on your screen and reads, my organization's work in compassion partners directly with which of the following? Again, please select all of the responses that apply. Quality or high reliability, patient experience, human resources, mission or spiritual care, clinical, medicine/nursing. So please go ahead and enter the responses that most apply to you. And once that is complete, we will go ahead and share the results. So we are just about there. Keep the answers coming in. We're excited to share the results with you after that is complete. Just a couple more moments. Go ahead and get those answers in. Okay, we have a good response. So let's go ahead and close the poll and share the responses. Let's see, we have 42% said quality/high reliability, 65% said patient experience, 22% said human resources, 61% said mission/spiritual care, and 56% said clinical, medicine/nursing. Becca and Mark, any thoughts on these results before we jump back into the presentation?
Well, of course, we're finding this very fascinating. We've had experience with all of these partners, and we really love the fact that patient experience is, I think, really getting so close to understanding it's the whole experience. If we really want to take care of patients well, we need to take care of providers well, or caregivers well. And of course, for those of us in faith-based organizations, this feels very close to the mission and the spiritual care of caregivers. So this is really fabulous. I mean, I think we've worked a lot with HR. I see that's a little bit lower on the list, but it seems like all of these are really valuable partners. So moving on, and just to close in this last part, is to talk about integration. Again, we've really tested ourselves around ownership versus partnership and really tried to lean heavily into the partnership. Looking for your partners in your organization can be along work streams, for example, developing leaders, can be with special departments, or can be as organizational strategic initiatives such as high reliability. We wanted to share with you some of what we've done with our partners. This is some examples, and as you can tell, we try very heavily to embed our work into partnership across the organization and with everybody. So again, just as you're thinking, if you're just getting going, or if you're already doing this, challenge yourself to think about partnership, because we really believe that doing this in tandem together is much stronger than trying to do it on your own. The next is about diffusing compassion. So like, how do we make this stick, right? Like, we can go and talk to a group and they feel good, but how do we really make lasting change? So here's a couple of ideas that we've been doing. These are new, so we can't really tell you how well they're working, but we are enthusiastic about them. One is that we started a compassion networking call that will be sharing across the organization. Anybody can join regardless of your role or affiliation. So you can join the call. There is a short lecture in the beginning on some topic. For example, we might present on grief or self-compassion. And then the latter half of the call is to really highlight what other people are doing across the organization to infuse compassion in their team or in their hospital or across their region. And we really have started to get some really good feedback about these calls and think that they will be wildly successful in really connecting. The next thing that we have done is to develop an internal website. We call it SharePoint. It's on a SharePoint site. And this is a go-to place for the entire organization. And what that allows people to do is have a central place to go, find out what's happening across the organization. Again, this is a great opportunity for partnership to get other people to add on to this website. You can see we're spotlighting the Compassion in Action Conference. So we try to also talk about what's happening across the nation as well as what's happening regionally. You'll see down on the bottom these conversations. So these are what we call our little bundles of compassion. So around burnout, there'll be a short lecture with speaker notes that, for example, a leader could use with their team. There will be YouTube videos, reflections, stories, group activities, individual activities, mindfulness exercises. So we create these bundles for either teams or individuals to just go in, pick out what they need. Some people are having retreats. It's a great way for them to be able to go and take this topic and embed it into their retreat. So that again has been, we've had a lot of positive feedback about that. And lastly, we just wanted to close on some lessons we've learned. We could probably go on forever, but here's a few of the highlights. The culture of compassion really belongs to everybody, and it's for us to create together. And again, it's about this partnership. The second is that we see ourselves as really being a catalyst, and coming into this work in a humble way is important. We try to always take the long view despite the urgency, despite our own need and feeling of wanting to fix. We try to think about how we can do things that will be sustainable and long-lasting and meaningful. We like to think about measurement as a way to energize the work versus as grading the work. And we like to provide frameworks and menus and ways for people to help co-design so they also own this, and it's not just coming from us. We always say to people that we don't have the answers, and that the answers lie within all of this and with all of us in the way that we do our work together. And last is really learning to be patient, to be curious and attentive to watching things unfold. Has really served us well to just know that this work is going to catch fire, unfold, and develop in the way that is best for your organization and for teams afar. And so with that, we just like to thank you so much for the opportunity to speak to each of you today. If you have any questions that we don't get to answer today, feel free to contact any of us. We'd be happy to address your questions later on as well.
Thank you so much, Becca and Mark. That was incredibly helpful and very practical and very heartfelt. I can just feel your compassion as you speak, and I know you both will. There were some questions that came in. I'm just going to pop right in with some of these. Are you ready to respond to some of these? The first one is, what definition of compassion did you use with your staff? Did you have some kind of a definition that you used across the various systems that you're involved in organizations?
Thanks for that question. Yeah, there are obviously a lot of different ways to structure it. We've used a definition that we took from Barbara Dewar, and it had to do with, the compassion is the recognition of the suffering of another, of seeing the commonality, and then being moved to alleviate that suffering, with always adding the caveat that alleviating suffering can be sitting with and holding as opposed to trying to fix.
Right. And I think some people there's a lot of sort of confusion over what is empathy, what is sympathy, what is compassion. I think there's growing consensus around the active part, the action to try to ameliorate suffering, even if you can't relieve it, as you say, by being with, which doesn't necessarily exist in some of the other definitions, for example, of empathy. Another question was that people want to know whether you were able to share the website link, your compassion website link, or is that internal only?
Sadly, it's internal only. We don't have a way to, I mean, not that we really don't want to share it, we just really literally don't have a way to share it.
Right, right. But people should come to our conference in June, because you'll be able to hear Becca and Mark describe a little bit more about their work at our conference. I wanted to ask something about how did you actually manage, I mean, you did a lot of measurement, which must cost, and I'm wondering how you got the buy-in to spend the money on all of the different measures that you actually implemented across the organization.
Well, so the way that we did that actually was through an HR partner. And again, this is where partnership's so strong. So he was instrumental in really believing and knowing, and also very heartfelt around the fact that caregivers were suffering. And so he knew about our work from talking, hearing us talk, and said, you know, what would you guys like to measure if we could embed something into the next engagement survey? So that's where we hit on 3 compassion questions and 3 burnout questions. And it was really through his advocacy that happened. And so it was just part of our normal surveying of caregivers. So it didn't really cost us, quote unquote, anything.
So you just customized some of the questions. That's fantastic. Amazing that happened, right. Actually. Yep. Yeah. And the work engagement was already part of your surveys?
Yeah, the engagement survey already existed, and it required us to work with Matt Griffin, who, if he's listening, I want to call out, but we ended up substituting items. So if you make the survey longer, there is a cost from that.
Yeah.
And so we ended up substituting and making choices of what is the thing that you really care about measuring, how are you going to use the results? And so I think that was the big push.
Yeah. Okay, there's another question here from our listener. Do you have any comments about the usefulness of management mandating these compassion-related activities? I imagine that forcing participation in these sort of cultural change activities might be counterproductive. Any comments?
Amen first. Yeah, so, you know, you don't have control over that. I can say that as system level people, we are sort of different than most programs that have existed at the system, which are used to developing a program that then gets filtered out. And we've always been very vocal about the fact that, again, when you're talking about teams and individuals and hearts, that we have to allow the individualization versus the standardization. And so, and we also, so our team, for example, never forces ourselves on anyone. We just go by invitation. And that has been a model that has served us well, and I think serves the work well. That when you leave it open for people to come to it, is a very different experience than if it's forced upon them.
That's really helpful. I don't know if we have enough time for this. Maybe one more quickie question. I know we're running out of time. But the quality bundles that you talk about, are these quality measure bundles or activities that you've developed?
We're just in the process of incorporating compassionate care as one of our quality bundles, along with urinary tract infections and central line infections. And they're connecting it to the previous question. The mandate has to do with having some activity that addresses burnout / compassionate care versus do this exactly. And so we're walking this fine line between needing people to take action without specifying what the action should be, how to educate and support people who want to take action but are unsure what exactly is the action to take. And that's where the framework becomes very helpful to people, and examples, we give menus of things that we've used before.
That's helpful. Well, our time is out, although there are many questions still that remain, but I want to thank you both, just a heartfelt thank for an incredibly effective and informative presentation. It was just terrific. So I guess I will welcome anybody to come to our Compassion in Action Healthcare Conference again, register, look at our website. You'll get into the registration site as well. Andrea, can I turn this over to you to close us out?
Absolutely. Thank you, Beth. I would again like to thank Becca Hawkins and Dr. Mark Rosenberg for sharing their insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope you enjoyed this third in a series of webinars focused on organizational cultures of compassion. These topics and more will be covered at our inaugural Compassion in Action Healthcare Conference to be held June 25th through the 27th, 2017 in Boston. To register or learn more about the conference, please visit compassioninactionconference.org. We also hope that you will join us for upcoming programs in the Compassion in Action webinar series. Please visit our website to see our upcoming programming and learn more about the Schwartz Center for Compassionate Healthcare and our membership program. We know you are very busy, but we would very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, as we value your input. Thank you and have a great day.